I'm looking at the Neighbourhood Mental Health Teams in Birmingham and Solihull. I am the Business Insight Lead for Birmingham and Solihull, as we've already said. I work in the ICB, but I'm embedded in the ICB. I'm actually employed by Midlands and Lancashire CSU, and I've been in post with a mental health specialism for, it's my 7th year anniversary, actually. So 7 years, which has flown by. Today, we're going to look at, first of all, a very brief look at the background to the Neighbourhood Mental Health Teams, and then we'll look at the reporting solution as it is currently. There's always room for further development. So the and I've got all the logos. I've been told to show you all the logos. Midlands and Lancs, Business Intelligence, Aristotle. We do have a consultancy unit at Midlands and Lancashire, commissioning support unit. So if you wanted any work done, then please get in touch. That's my sales pitch. Right. So the Neighbourhood Mental Health Teams are a deliverable of the Mental Health Community Transformation program in Birmingham. And what that means in practice is mental health workers are now embedded in primary care across Birmingham and Solihull. There's 4-step aims to the project, or there was when it started, and that's swift access, multi-agency help, reduce inequalities, and remove barriers to access. And the idea is that by putting mental health support in GPs, it would make it much easier for the patient to access. So we looked at building a reporting solution to try and monitor some of those outcomes and just to generally monitor activity. The source we chose was the MHSDS Commissioner extracts. And for those of you who are not familiar with the MHSDS, it's the Mental Health Services data set. It's a patient level data set. It's got about 60 different data tables. It's a huge schema. And everybody who is funded in part or entirely by the NHS to deliver mental health care must package up their data every month and send it in the format of the MHSDS to NHS England. NHS England then compile those extracts into one big data schema, and they use that themselves to produce their national statistics. But it also gets packaged up and sent out to CSUs. So Midlands and Lancs is one of those CSUs. So we get a copy of patient level data for all the patches that are within the Midlands and Lancashire CSU footprint. So we're using the MHSDS. That does mean that there is a bit of a delay. So when for the activity page, it's not as timely as maybe managers would want, because it takes about 6 weeks to turn that around when the MHSDS is operational. We did try in the pilot to use clinical systems directly. I wouldn't recommend it. This is how I feel after that pilot. It was very, very difficult to get information out of clinical systems, and then it was all in completely different formats, and it all had to be messed around with, wrangled every single month, and every month the formats could change. So I really wouldn't recommend that. I mean, things are moving on with the GPES data extract, but we still haven't got broad access to that. In the pandemic, access to primary care data got suddenly a lot better, but that access has been withdrawn. So we felt that the MHSDS was the best solution. And it's been reliable. The wrangling that I do from MHSDS data, I just do in SQL. So I'm an SQL coder. I visualize in Tableau. That's my platform of choice. And the data viz platform that's accessed by everybody who wants to see this report is Aristotle. Aristotle, if you've not heard of it, is the data visualization platform that Midlands and Lancashire CSU primarily use and market, for better or for worse. So this is the dashboard that I've built. This is the front cover. As I said, it's built in Tableau and mounted on Aristotle. So this is the live Aristotle version. And these are the contents that I'm going to go through. So the first one is just an activity overview of what's been happening, numbers of referrals received, brief demographics, that sort of thing. The second 2 pages look at the prevalent population, and by prevalence I'll explain what I mean by prevalence when we get there, and then the proportion of prevalence, portion of sick people who are actually accessing this particular service, and so we'll go through that in a minute. And then this section looks at the proportion of patient characteristics such as gender or ethnicity in the community, in the population, in the general population, compared to the proportion of that characteristic in the neighbourhood mental health team. And that's to, again, look for equality of access. And also you see which groups are accessing more than others, which sometimes tells you a little bit more about where the prevalence actually sits when it presents to services. And then there's a couple of sections here to look at assessment tools. Assessment tools, or outcome tools as they're known, are NHS England policy for mental health services that more and more of them should be used. And they're basically, for those who are unfamiliar, they're basically questionnaires. And it's a questionnaire that you deploy to the patient, and you deploy it more than once during at different points in their treatment. So you end up with before and after scores, and you compare the earliest score to the latest score to see the difference. So we'll have a look at whether those have been deployed, and then we've got one dashboard that looks at dialogue, which is one assessment tool for adults. And I have also built another dashboard that looks at RCADs, but that's for 0 to 18s. And if we get time, I'll have a look at that as a little bit of a counterpoint to dialogue. So the activity overview, this was just the first thing we built just to get an idea of what was happening in the service. It's quite high level stuff, really. It can be filtered by each locality in BSOL. So the key facts from it are now I just also ought to say that this stops at the end of March in terms of data coverage at the moment. And that's because the MHSDS version 5 finished, and we're now on version 6. And I've just received version 6 data, and I'm now working to deduplicate it and get it in an analysis friendly format. So there's a bit of a lag. But this is as it was at the end of the financial year just gone. In this period here, so from Q3 2022-23 to the end of Q4 just gone, there were 16,400 odd referrals received that had a contact. The average contact duration was 34 minutes. On average, each referral gets 2.1 contacts, and the average referral length is 4 weeks. 73% of referrals are getting a first contact. The DNA rate is 34% overall. And the average wait is 21 days from referral receipt to first contact. That's actually pretty short for mental health services, and it's a lot shorter than functional community mental health teams that this service was sort of, I think, designed to try and help in a way. And you can see that there is a significant proportion that really don't wait a very long time at all. 1 to 3 days. That's 26% is very short, and it does taper towards the shorter waits rather than the longer waits. The age of patients presenting skews towards young working age adults, so 26 to 35 is a quarter of patients that have presented in this period. And the reason for referral is primarily depression and anxiety, but there are all these different reasons here that take up much smaller proportions. So yeah, the gender balance, it's majority female, as you often see in mental health services. And this is just some data quality stuff for the service. We're trying to get protected characteristics better recorded so we can start to analyse that data. But as you can see, there's a way to go in that work. So the next section is a bit more strategic, if you like. This looks at the proportion of people who are sick, those that are prevalent, that are accessing just the neighbourhood mental health service. So not the wider secondary care, it's just this service. And the point of this is to look to see if access is equitable across the Birmingham and Solihull geography. So it allows us to compare different areas, even though the population volumes might be different in those areas. So the prevalence that I'm using is the prevalence from Public Health England Fingertips website. And for people aged 5 to 15, it's any mental disorder. I think this service is for adults, so that doesn't really get used. But common mental disorder is for people 16 to 64 and 65 plus. There's different rates, and there's different rates for Birmingham and Solihull. So you can see in Birmingham and Solihull, adults 21% will have a common mental disorder, and this is sort of mood and depression end of the mental health scale, whereas in Solihull it's lower, quite a lot lower. Solihull is a very, very different. I mean, I don't know where all you people are from. Solihull is a very different geography, demographically, compared to Birmingham. Birmingham's one of the most deprived cities in Western Europe, I think it's fair to say, whereas Solihull is a very affluent area. This is Solihull here, these two spots here, Solihull and Meriden. It's quite rural in places, whereas Birmingham is very built up and has high deprivation. So what we do, the working out for this, this heat map here shows you what proportion of the prevalent population are accessing services. So you can see that we've got a real access cold spot in Solihull, which only less than 1% of prevalence is accessing the neighbourhood mental health teams, compared to Erdington right next to it, which has 9.5% of prevalent population accessing. And this is based on the patient's home address. How we work this out, so for Erdington, where are we? How we work this out is in Erdington, there are 72,000 people. So we apply the prevalence rates down here to that, and we get a prevalent population of 13,700. And then in Erdington, there are 1,300 accessing. If you divide this number into this number, hopefully you get 9.5%. That's how the working out is done, essentially. So in Erdington, if we wanted to look, I'll stop at that point because that sometimes bamboozles people. So I'll stop. Any questions? No. Good. Okay. So this is essentially about equitable access across Birmingham. And as you can see, actually, compared to other services that I do similar analysis for, access is more equitable actually for this service, because these colours are all fairly similar. There are some cold spots. Hodge Hill, Sutton Coldfield are sort of, and maybe Ladywood are outliers, but the rest are, you know, maybe they could be close. I don't think you're ever going to get them all totally to parity, but what you don't want to see is real variety across the piece. So if you then want to think, well, what about inside Erdington? Is it equitable? The next dashboard just takes you down that extra level. So you can click on a particular locality, see the parliamentary constituencies, but then also see the wards that sit inside those parliamentary constituencies. So Erdington does have the highest access rate for this team inside Birmingham, but then you can see different parts of Erdington are similar but slightly different. So the highest access is coming from Perry Common in Erdington, and the lowest access is coming from, where are we, Pipe Hayes, but you know, reasonably similar. If you break Solihull down into its constituent parts, and you can see you do get variety across Solihull. For those who have, you know, local knowledge, North Solihull is a very deprived area, and we do get a higher access rates in here, but it's also where a lot of mental health services are located because it's a more deprived area. And I think that's part of the context that sits behind some of this analysis. When you this page, again, exactly the same working out, but it's all laid out here by ward, and the prevalence is down here, and it also splits it out the proportion accessing for each IMD quintile. And as you would expect, those that live in the most deprived areas, which is the lowest IMD, so 1 is most deprived, are more likely to access services. And I think that's, I mean, if we skip through, that's pretty much the same across the piece. And you'll find some areas don't even have the higher IMD areas. Some areas, the more affluent areas, some areas are just most deprived only. So there is a bit of variety there. Interesting. Okay. The next page that we've got, this looks at patient characteristics. And what I'm going to do is just switch that to all localities and switch it to gender while I explain it. So this looks at representation of particular patient characteristic compared to that characteristic in the population. So this is the example of gender. And so this is the work, if you put the hover over here, it gives you the working out. So in all localities across Birmingham and Solihull, 48% of the population is female, 48.9. In the neighbourhood mental health teams, 60 or 61% of the patient cohort are female. So there's a higher ratio of females in service compared to the general population, and we did see that on the activity dashboard, didn't we? So what I do to express that visually is I just divide the ratio in service into the ratio in the population. So 60 divided into 48 gives you 124%, so that's overrepresentation. And then I subtract 1. So if it's overrepresented compared to the population, it's a positive figure. If it's underrepresented, it's a negative figure. And that just means it plots nicely and it's easy to interpret the charts. If it's in balance with the population, then it would be 0. If it was 60 divided into 60, it would be 0 or 1 before I subtract the 1. So that's the easy one to explain it. And then the different characteristics that can be examined are age. I'll skip to age. And here you see that the patients that are accessing services primarily, as we saw in the activity, are those of younger working age. And you find this a lot in mental health data, that prevalence isn't the same for every age group. What people who access services tend to be younger working age people. I mean, that's not necessarily to say that people who are retired or early retired don't necessarily suffer from mental health conditions, but for whatever reason, they're not the people who access the services as much as younger working age adults. And that pattern of, so this page, if we can also filter it by localities, because these are locality-based teams, so they're interested in their own area. So this is the central locality in Birmingham, and that is comprised of Hall Green and Selly Oak. And then it does break it down by wards here as well, which you can click on a ward to see that particular ward. But I was in two minds whether to put wards on, because sometimes the volumes can get really low in wards, which means percents can get really skewed. So I do say just interpret these wards. You can always see the working out to see the volumes, but so for that particular age band, I'm hovered over there. It's only 14 people accessing, so I'm always a bit. I nearly didn't put it on, but anyway, it's there. So yeah, and the age profile across all the different localities, it's always pretty similar in that it's working age adults. Solihull has an older population, but again, it's still working age adults that are accessing. And you might say, as people who run this service, you might say, fine, that's what we want. Or you might say, actually, maybe we need to market ourselves to different age groups who aren't accessing. We've already looked at gender. If If we look at IMD, so yeah, we've got more access in the more deprived areas for central, and slightly different picture for east, but still, yeah, similar for north, where it's the most deprived who are accessing. Solihull, yeah, it's the same. So you do tend to see that trend. I mean, I've never seen the trend where the more affluent areas are driving access, to be honest. And then ethnic, if we go back to central, in terms of ethnic group, now this is skewing the data, this not known and not specified. It's because in the, if we look at all localities, they've got a bit of a problem with coding ethnicity in this team, and it does drive me bats. So across all of Birmingham, there's only 4.5% of the population where we don't know the ethnicity. But in the service, it's up at 20%, and that's why it skews the data. And now I could impute this information, ethnicity, because I've got pseudo NHS numbers, so I could pull it in, but I leave it there to try and get them to fix their coding. And I should say, when I'm comparing this to the population, the data source for the population is the NHS spine, so that's bang up to date population data, basically. So that's where I'm getting that from. So it's not census data or anything like that, and that's why it's so nicely granular in terms of geography. It's because it's from the NHS spine, and I map it using pseudo NHS number, which allows us to map our data sets together at patient level. So that's very useful to have. But if we ignore this skew for a moment, you tend to see that people of white heritage are accessing the service in balance, or usually they're slightly overrepresented in service compared to the population, and then the other ethnicities tend to be underrepresented, and that's a picture that is pretty common across the piece. That's central. See there, we've got overrepresentation, and you do tend to get overrepresentation of mixed or multiple ethnic groups. Sometimes I'm a bit skeptical that the coding is perfect on ethnicity, so sometimes you have to interpret it with a bit of caution. Similar picture there in the north, and same in Solihull on the south. So Birmingham is a very diverse city, so to consistently see Asian, Black and other ethnicities underrepresented right across the city is a bit of a problem that I think the service is trying to address. I do have another, I'll just quickly look at something else to show you the demographic makeup of Birmingham. You might not be familiar with it. There we go. Again, this just takes NHS spine data and maps it for Birmingham. So this is Birmingham and Solihull, and this is the ethnicity groups here. So across all the areas, it's 48% white and then more diverse. Solihull is very different to the rest of the geography. So it's 75% white and then other ethnicities here. It's quite a big Asian population in Solihull. It's also an older population if you look down here. And it's also, if you look at affluence in Solihull, there's 39% of people are living in the most affluent quintile, and 16% are living in the most deprived. If you then look at the east of Birmingham, which neighbours it, you get a very, very different picture. You get a younger population, you get 50% Asian, which is majority, well, the cluster in the Asian population is Pakistani, so it's a big area of Pakistani heritage. And in terms of deprivation, we don't get any more affluent than IMD quintile 3 of 5. So 81% of people live in the most deprived quintile. So that's what we're looking at in terms of Birmingham patient characteristics. So if you're in the east and 50% of your population, well, it's not 50%, is it? It's 70%, mental maths, of your population is non-white, then it's a bit concerning when you're in the east and you've got an overrepresentation of people of white heritage in service and an underrepresentation of those other areas. So, and then if you want to drill into the groups that sit inside these summary groups, then the ethnic detail, that's it here. So when you're looking at Asian, it's not all one thing. So we've got Pakistani and what's the other one? Indian there. So you sometimes you get an overrepresentation of people of Indian heritage in the east, an underrepresentation of people from Pakistani heritage, and then Chinese. There's nothing there plotted for Chinese, but in Birmingham we tend to have an underrepresentation of people from Chinese heritage. In terms of black ethnicities, Caribbean tends to be broadly in balance with the population or overrepresented. So people of Caribbean heritage, there's not really a problem with them accessing services across the city, but people of African heritage, you do tend to get, and this you get this right across Birmingham, you do tend to get a big underrepresentation of people. And again, this is just for the Neighbourhood Mental Health Teams service, but a lot of this data is fairly representative when I compare it to other reports that I do. I'm going to stop there for a second. Any questions? Someone said, can we access this dashboard? You can access it if you work for Birmingham and Solihull Integrated Care Board. Otherwise, it's a data sharing issue, really. So you would need to have a data sharing agreement and you'd need to get in touch with Midlands and Lancs, basically. If you wanted something similar building, then Midlands and Lancs can do it for you, but they may charge. So any more? Shall I carry on? Yeah, I'll keep going. Right.
John,
Alistair.
just on that. Yeah, I know you said that, and I do understand that about that you'd need to be working for the ICB, and presumably you'd need to be actually employed by the legal entity of the ICB rather than just within that patch. So if you were in an NHS trust supported, covered by the ICB, that you'd still be in data sharing issues, wouldn't you?
Well, this is all currently being discussed because what I think the chief analyst and all of us who are analysts want a single data environment, really, for an integrated care trust, integrated care board. You can't, if you segment the information available to people and silo it, that's the absolute opposite of integrated care, right?
Yeah.
But we're in a situation where we've moved into the ICB world and now we're having provider collaboratives. People move from the ICB into these provider collaboratives, such as the Mental Health Provider Collaborative in Birmingham, which has moved into Birmingham Mental Health Trust. And now there's issues about them accessing system-wide data, which is the absolute opposite of integrated care. So that there is a live conversation going on to try and get that sorted, so that we won't need to have multiple data sharing agreements across all the healthcare providers in Birmingham and Solihull. It will just be they have the ability to see this information as is. I mean, this information that you can see on the screen, this is summary information. It's aggregated. There is no way you could identify a single patient from this information, none whatsoever. If we get a freedom of information request in, we would send out this information without hesitation. You only have to worry if your volumes get below 5, but then even then, if your volume's below 5 and it's over a large geography, then you're not going to identify that patient. So, my view is let's be sensible and share the data more. So
Right, well,
hopefully that will happen. That will come down the track.
That'd be amazing. Thank you.
So the next section then looks at assessment tools. Now, this just looks to see, this first one looks to see which teams are deploying assessment tools with their patients. And you can see that for the vast majority of teams up until March, it might have changed, up until March, they were not really routinely deploying assessment tools. So you got 1%, so 29 patients there. I've got a tool, 15 there, 6 there. So it's pretty woeful at the moment. The tools that have been deployed are Dialogue, Honos, and this Core OM. I've got 5 of those. So there's only 3 different types of tool being deployed. So this is like an area that's in development for this team. And what we want to see is paired scores. We want to see the before and after scores. That's where we can get more meaningful information. But that's not to say single scores are useless. They still give us a feel for what patients have turned up with, if you like. So the tool that is used most, albeit only 68 times, is Dialogue. So I've built a Dialogue dashboard for this team to try and get the team a feel for the information that this can tell them. I've kind of, I say hobbled, but I've put this together myself, really. So there might be people who are more familiar with Dialogue and just think, well, I wouldn't do it like this, I wouldn't like to do it like that. But that's how it is at the moment. This is a Dialogue dashboard. As I say, it's got 65 single first scores, which are here. It's only got 3 paired scores, so this chart here doesn't really work because you need paired scores. But this chart here is valid, I suppose, for this small number of people. And this shows you where the explicit dissatisfaction is for the patients on their first assessment. And so the dissatisfaction isn't with mental health professionals, really, not with personal safety, but they are all. There's a lot of patients, 66, who are showing explicit dissatisfaction, whether it be totally dissatisfied, very dissatisfied, or fairly dissatisfied in the mental health sphere of their life, followed by physical activity, leisure activities, job situation, and then it tapers down: friendships, accommodation, partner, family, personal safety. So this gives you an idea of how you might, and I'm not a clinician, this isn't a clinical opinion, but how you might tailor care to meet the needs of the patient. Because if you see a lot of people are turning up to your service with physical health, they're explicitly dissatisfied with it, or leisure activities, then there's an avenue there, isn't there, for treatment to try and fix that. So when you do get the last scores, you get a better view. There we go. Right. So hopefully you can see that. So this is one where we've got, again, it's not massive volumes. This is an example where there was more data. And this is where we've got 101 single first scores and 27 paired scores. And that just allows us to see this chart plotted. And what you want to see is a negative score, because you want to see the percent of patients who are dissatisfied in a particular area. You want to see that proportion drop. You want to see dissatisfaction drop. So for those where there are before and after scores, it's the job situation that where the dissatisfaction decreased, so that got better for those patients. The mental health area got better, friendships got better. Those were the areas that really traveled the most distance, and then it's slightly smaller distances for these other areas. Medication also traveled quite a long distance, although they weren't as dissatisfied with that area at the beginning. You can see that they were very dissatisfied with job situation. And again, this isn't the neighbourhood mental health teams, this is just more general data, but it just gives you an idea for the information we can learn from assessment tools. And this is an area I'm just getting into, really. I've done another one, which I'm just going to share with you, which is to do with RCADs. So that's we had quite a lot of RCADs, which is revised children's anxiety and depression scores for BSOL. So I've got a different workbook that looks at RCADs. Hang on a second. Where are we? Come back. That's it, yeah. So this is 0 to 18s across Birmingham that are in secondary mental health care. And this is RCADs. So it's a similar setup at the top here, but it's a different clinical tool. So it's revised children's anxiety and depression scale. And RCADs is a self-reported questionnaire that assesses symptoms of anxiety and depression in children and adolescents. The assessment contains 47 questions that are scored never, sometimes, often, always. Responses are then grouped into subscales. These are the subscales here: social phobia, separation anxiety, depression, panic, generalized anxiety, and obsessions and compulsions. And then these subscales are totaled to give you a total anxiety score, a total anxiety and depression score. And the raw scores are converted into T-scores, and T-scores allow standardization across age groups and gender. So people score differently based on their age, whether they're young children or whether adolescents, and their gender. And so T-scores adjust all that and take that into account, which means you can compare it all together. So for this, I'm only looking at paired scores. I've got it filtered here to only look where there are pairs, and there are where are we? How many paired scores are there? 359. Oh. Yeah, no, there's 526 referrals where there are paired scores, but they don't always answer all the questions, so that information is there. But what this is telling us, essentially, is that for Birmingham and Solihull, and this does all the MLCSU patches, but for Birmingham and Solihull, in terms of the subscales, it's panic, depression, and separation anxiety that score the highest, so where it's more acute for patients in those areas. In terms of distance traveled, it's all fairly similar. The most distance traveled in terms of reducing is social phobia, but you get a consistent reduction really across the piece. When I segmented this by demographic information, this is average change for anxiety. So it's this one is the same here, and I'm just segmenting it by IMD. And when you do that, you see people who live in the more deprived areas, they actually travel the least distance compared to people who live in more affluent areas. They travel more distance, which means they get more better, basically. And for gender, is there a difference? This is just for Birmingham. It's slightly different in each area. Gender, there's not a massive difference in gender, and in ethnicity higher. Again, there's not a bit more of a difference, but not a massive difference. It's a bit of an outlier here. Yeah. So again, this is quite new. I've only just done this, so and until we get more volumes, I mean, 526 is better, I suppose. But until we get more volumes, then at the moment it's just exploratory information. This looks at these charts here. Look at the first scores and the last scores. Again, for each of these subscales, it's the same subscales. And for the first scores, these are the percent that are below the clinical threshold, and these are the clinical thresholds here in terms of T-scores. And on the last score, I just plotted this to see if we get a lot of patients that move below the clinical threshold. And yes, you do get that. So it moves from 55% below clinical threshold to 61% on their last assessment. So there is movement below, but actually you do still get quite a lot of patients who remain above the clinical threshold when they're discharged. So that was a surprise to see that information. Now, I'm not a clinician, so maybe that is what you would expect to see. You do see movement where people reduce their acuity from first to last scores, but you do still get a proportion of patients on their last scores. And this is just looking at discharged. I'm only looking at discharged referrals. So it's interesting information, and as I say, it's new stuff to look at. It's new that we've got it with real volumes now beginning to come in through the MHSDS. Right, so yes, it brings me to further developments. The dashboard's not finished. It's still, I mean, I tend to always get pulled onto other things, but it's still a work in progress. So at the outset, the Neighbourhood Mental Health Teams wanted to look at the wider system impact. So the idea is that there'll be less traffic into mental health secondary care because the need will be met at the GP level, at primary care level, and it won't escalate in acuity and end up in secondary care teams. I haven't got round to working out if that's happened or not. And also other healthcare settings. So do we have reduced presentations at A&E? Do we have, reduced presentations at 999, 111, inpatients, outpatients for physical acute? I haven't yet done that analysis. I would like to have time to do it. And then there's other outcome tools to look at, as we saw. And then also I haven't really properly delved into inequality analysis for waiting times. And then trying to change. And then I think there we go. That's it.